Many of you are already getting ready for Thanksgiving, I think. But what I'd like to do is start this off, since it's a Thanksgiving COVID update, is to thank all of you out there, and we'll be seeing things, hopefully seeing this recording as well. But as your health officer, I truly appreciate all that you guys do. Everyone, the CHAISR organization, and all the clinics that we have here that help the people in our community of San Bernardino County. So it's a pleasure to be of service to you as your health officer, and to join you in this war. And what I want to do today is talk about COVID, but I really give you some of my thoughts on the theory of my daily research on what's going on in terms of some trending that's going on with COVID, where we are. And I introduced that word endemic as opposed to epidemic or pandemic. And the reason for that is, those of you who know epidemiology, is a pandemic or epidemic is a new phenomenon, and it's a massive outbreak as opposed to an endemic infection, which basically is a regularly occurring phenomenon. And I think that may very well be where we're headed with regard to the COVID. But actually, I tack on winning the war, because I think we've got a lot of things coming up that will give us the edge in taking care of this insidious virus. So what I want to talk about today was I'm going to go through the status of COVID-19, both in San Bernardino County and nationally. I want to talk about the Delta variant a little. When we're talking about variants now, we're just talking Delta because it's 100% Delta now. I want to talk about the phenomenon of waning immunity, because that's it's critical for all of us to understand that when we want to understand the role and the necessity of boosters, and also we can touch also on the phenomenon of natural immunity, or infection-derived immunity versus vaccine-derived immunity. And then I want to talk about the vaccinations, give you a status update on where we are in the county primarily, but also nationally. A little advertisement or ad for the safety of the vaccine, because I think that's important that we all know, we all be able to communicate to our patients. I want to talk a bit about the pediatric vaccines from Pfizer that was released 2-3 weeks ago, and the boosters. And then I'm going to talk about some cool new stuff. The new therapeutics. We actually have medications coming out that will allow us to actually treat people who have the COVID infection and like an antibiotic. So that's exciting, and I'll talk to you about that and why I'm saying right now we have the weapons to win this war. It may not be the complete extinction of this virus, but we're going to be able to minimize the deaths and the hospitalizations, and that's basically what it's all about. And then I want to also finally talk a little bit about what Dr. Vivek Murthy, our Surgeon General, has called a secondary pandemic, which is the misinformation that occurs around this vaccine and around the disease, that's really hampering all of our efforts to be able to get this under control, and I was going to say and get rid of it, but we're not going to get rid of this, I don't think. That's a personal professional opinion. So let's talk about San Bernardino County. First, this is COVID-19. So we've had this is data as of yesterday. We've had 358,322 cases total. Our case rate now is 15.5. It was 15.7 yesterday. So it's gone down a little. The positivity rate is 4.8%. That's the of all the tests that we get, the percentage that are actually positive, all the tests, and then our equity, which is the positivity rate in our healthy places index first quartile, is 5.4%, and yesterday it was 5.3%. And there's a phenomenon there, just slowly creeping up. And I'll give you some corollary data that kind of explains why the equity positivity seems to be inching up. We've had 5,897 deaths so far, and that actually has been fairly stable. We've had only one in the last week and a half. So the deaths are, and they're primarily unvaccinated patients. And we do 457 tests per 100,000, which is a good healthy clip now. So I wanted to show you basically the path of this COVID and what's happened since, we had the July peak, and then we had the big post Thanksgiving and Christmas. Here's Christmas. So we've had Thanksgiving, Christmas of last year, and this was when we were drowning, right? All of our hospitals were full. We were running out of oxygen, running out of ventilators, and then we basically got everything under control. We shut down society. Everyone masked and distanced. We started to get the vaccinations going, and then we hit a nice plateau where we started to think, wow, we may be getting this under control on the way out. And then what happened? Delta. This is the Delta peak now. And what's happened here is what you see is it peaked a little in August, and basically look right here. Now it's just kind of plateauing, and it's just being stubborn. And I'm going to explain why it's being stubborn. And hopefully we'll be able to keep this down here really low. And I think we can. So let's talk about vaccines. It really is the key. If we could get everyone vaccinated and boosted, we'd really be doing kicking butt and doing what we need to do. But can we or not? I know you, my audience, you out there, health professionals, we're doing everything we can. The thing with public health and dealing with our populations is we can't quit. Okay, as long as there are people getting sick, people at risk of dying, we can't quit, regardless of their beliefs. And at some point, we have to feel that we've done our best, and doing our best really is all that matters in terms of that. The rest will follow. Okay, that's a saying that my dad used to teach me because I always tried too hard. So for our county, we're at almost 61%, at least one vaccine, 54% completely. For our HPI quartile 1, we're actually doing better than the state average for this, for sure. And our quartile 4, we're at 72%. Our African American population, we're at 29%. The Latinx, 46%. Our indigenous population, 22%. And that's tribal primarily. The worldwide and US, I throw this in because I want you to be able to use this and know of the numbers. Okay, 7.75 billion vaccinations so far. I mean, billion. In the US alone, this is as of yesterday, 455 million vaccinations have been given. The high, with no deaths directly attributable to the vaccine, one of the safest vaccines in the history of vaccinations. This was just recent data this week. We've given over vaccines to over 3 million children, ages 5 to 11. There's no cardiac myositis so far. We just have the local flu-like reaction for 2 to 3 days. So we're moving along. We can't rest, obviously, in our county, and it's not for the effort of our community-based organizations or you or me. We got to keep going, but people are just not quite jumping in yet, and we've got about 25% of our population there just refusing. So we'll be there for them, but and that's the purpose of the second part of this presentation, where we talk about therapeutics. This is the big thing. 2 or 3 weeks ago, we moved our eligibility down to ages 5 and above, and that's primarily with Pfizer, right? It does require parental guardian to be present and to sign. We have it at our county sites, pharmacies, state sites, and remember the dosage change. Okay, between age 11 and 12, we've had some administration errors. Both locally, not just one locally, but quite a few in California, and I'm going to talk a little bit about that as well. Remember the Moderna and Johnson & Johnson authorization still they're still awaiting FDA. And remember, we have the only vaccine that's FDA fully approved, not EUA approved, is Pfizer. Okay, so it's important to remember when we talk about crossover vaccinations from Sinovac and AstraZeneca, other types of vaccine. Okay, so that I'm going to spend a little time here because everyone when we introduce something different, it's going to create the potential for error, right? Every time you have a new process, you've got to be able to hardwire it. And how can we hardwire things that change every month or two? It's difficult, and I'm forgiving. Let's be forgiving. Errors can happen. Let's just make sure we control it. We QI it and make sure it doesn't happen again. So this is the adult formulation. It's in a purple cap. Okay, this is for 12 years and over. This is the orange cap for the pediatric. It's really important just to be able to stress this, get these separately. When the cap comes off, it's really difficult sometimes to keep track. So just make sure you keep them separately. Okay, there are families that come in, and the one error that I've seen was 2 brothers that were just a year and a half apart. So it was difficult. They're same size, and one got the adult, one got the pediatric. The dosage is 1/3 in the pediatric. Okay, the volume is 0.2. Fill volume is higher. There's more diluent, right? And the diluent's a little different too. So, and then doses per vial is 10 for the pediatric, 6, okay, for the adult. This is the ULT freezer, the regular freezer, and then with refrigerator, it lasts up to 10 weeks. Okay, just wanted to go through that. Basically, you cannot use the current formula as this is the question. This is a CDC slide. Can the current adult be used to vaccinate children 5 to 12? And this is no. For children under 12, you cannot use the current formulation. It's got different diluents, and it's a different dose. And even though an 11-month, an 11-year, 10-month, or 11-month-old is in 1 month, in 1 or 2 months is going to be a 12-year-old. It's basically stay by what's been approved, even though it's probably safe. Stay by what's been approved. So if they're 11 years, 11 months, give them the orange vial pediatric dose. If they're 12 years and they just turned, give them the adult dose, the 12 years and older dose, the purple cap, okay, the 30 micrograms. So that's important. Let's just, and I know I can turn the boat and argue, physiologically, are they any different? Probably not, but this is what's been approved. And there are physiologic changes as you go into puberty, and the 12-year age limit was not picked arbitrarily. Okay, there are changes in general in the population of 12-year-olds as they basically approach adolescence and puberty. So let's talk about the booster shots. Okay, why are they necessary? And are they necessary? And obviously, it's a leading question. They are necessary, and I want to talk a little bit about the background and all that, and where we are in that as well. So to talk about boosters, we have to talk about the Delta variant. You saw that little bump. We're in the Delta bump right now. The Delta variant, this is one really hardy variant. Okay, it's highly infectious. Okay, more than 100 times more infectious than the original virus. The R naught is without vaccinations, distancing, masks. That's why it's 0. How many people would one infected person infect? That's the R naught. Okay, with the Delta variant, it's 6 to 7. Okay, so the R naught for the Delta virus is 6 to 7. The R naught for the original virus is 2 to 3. It's rounded off to 2.5. So, at least 100 times more or double. Okay, so much more infectious. Okay, it seems to not respect younger people. So far, since we've discovered the Delta variant, and we are doing whole genome sequencing and looking at the genetic tree of these, what we call the clades of all these variants, there have been 160 subtypes of Delta now that have emerged. So that's one of the biggest reasons to slow down the growth of this virus. The way we slow down the growth of this virus is we slow down the infections. Okay, so there are 160 subtypes already, and it's growing. Okay, so none of them have really, and the subtypes are A.Y. and then a number, right? You've seen there's an A.Y.44, which is seems to be the most of all the subtypes. Has not changed the Delta variant's transmissibility or its virulence. Transmissibility we refer to as the amount it can be, how infectious it is. Its virulence is how deadly is it. So how bad a disease does it produce? We do know that the Delta variant has a shorter incubation. Okay, 3 as opposed to 5 in general, and patients that have the Delta variant shed longer. So vaccinated patients are not, and this is important, are not immune to Delta. Okay, what the vaccine does though is it limits the Delta infection primarily to like a cold or a bad flu. Okay, or not even a bad flu. You just get a flu. The hospitalization rates are much lower, and the death rates are much lower with the Delta as well. But it's important to recognize that vaccinated patients get Delta. Number 2, it's not as virulent. Number 3, it basically can affect so many people, and the vaccine prevents systemic spread of this virus, and it's because it really creates it kicks in our immune system, our B and T cells, antibodies and T cells. So, and then this is important. The whole concept of waning immunity. I'm going to talk about that now. So, what what's happened and why we've had the boost is we found in countries like Israel, and I'm going to talk about some of those studies that are highly vaccinated. And in our country, which is relatively highly vaccinated, we started seeing this bump again. Okay, when we looked at this bump, we said, it's all unvaccinated, but no, there were vaccinated patients in there. So we started looking at this, and there were multiple studies. This is pre-Delta and Delta. These are pre-Delta and Delta. Okay, we found that the vaccine, this is V, or vaccine effectiveness. Okay, and this is measured. This is a cumulative thing, and it deal multiple studies, and it deals with infection and with antibody measurement. Okay, so this is for people over 65, and we found pre-Delta and Delta that the vaccine efficacy has gone down. Okay, and people with underlying medical conditions, it's kind of stayed up around 85%. And frontline workers, the HERO study, just with mRNA vaccine efficacy has gone down with the Delta. Okay, now then we looked at basically more specific studies, because remember, if you just measure antibody levels and IgG levels, it doesn't necessarily predict and measure a person's immunity. You also have to look at the T cell, and it's a very specialized test to really measure T cell immunity, and the B memory cells. Those are the ones that can actually go down and go to sleep when it gets re-challenged by the same antigen, the spike protein. They kick back in. So we looked at multiple peak antibodies, and we found that for these mRNA, this is Pfizer, this is Moderna, the high peak antibody responses declined sharply by 6 months. These responses declined further by 8 months. So we looked at our antibody titers then for Moderna, okay, and they were generally higher than those of Pfizer. So so in general, Moderna, the Moderna vaccine seems to produce a little longer immunity, up to, a little bit, especially at 8 months. The 80 is adenovirus 26. That's the Johnson & Johnson. It induced a lower initial antibody, remember 60s, 65%, but their responses were stable over the 8-month follow-up with minimal to no evidence of decline. So at least it wasn't as high with Johnson & Johnson, but at least it's holding steady. So, and actually at 8 months, the antibody response is similar to Pfizer. Just Pfizer at 8 months is like 70%. So this just came out this week, a study from Qatar in the New England Journal of Medicine, very respected journal. There was a significant increase in infection after 6 months in their very tightly, highly vaccinated population. No waning of protection against hospitalization and death. And this is important to know as well. But we want to decrease the infection because we want to stop this virus from growing and mutating. Okay, so that's the reason. And then there's an important Israeli study. The Israelis managed to get close to 95% vaccinated because they're a really tightly contained population, and they're quite militant in making mandatory vaccinations. So they had a significant mass vaccinations. The infections were almost eliminated, and then they noticed a resurgence. So what's going on with that, right? So it showed rates of infection increased 6 months later in all age groups, and the rates of hospitalizations, but not deaths. So, and then basically they showed that the waning was worse with men, people over 65, smokers, and people with immunosuppression. So, and the Israeli study clearly showed the waning immunity phenomena that we pretty much have accepted now. So that's led us to boosters. We started, remember, with the people with immunocompromise and who are at multiple risk factors. We now, as of this week, have cleared it to give a booster for all adults over 18 now, all patients over the age of 18. And ideally, it's for people 6 months or past that in terms of since their last full dose of any of the vaccine of our 3 vaccines. Okay, the rationale already, I've hopefully established the basis for that. We've had waning immunity. We've got this Delta variant, and we've got continued vaccine hesitancy. We still have to get these people. As of 11/22, it was aged over 65 and at-risk patients. Anyone who sees people, basically, frontline personnel, care workers included, and there's the 6-month period, and we can boost any of the approved vaccines. And I'm going to talk about cross boosting in a second. The best antibody and infectious response is those people who've had COVID naturally, who then get vaccinated, and then they get boosted. They have amazing antibody responses and immune responses. I mean, over probably 98% in fact protection. So, and we haven't seen any increase in side effects. And everyone, I guess I get it in terms of you get that flu type response for 2-3 days, and you get a sore arm and a headache and fever and achiness, but it's just 2 days. I just really wish people would think more long term about that. It's just 2-3 days, and it's a legitimate reason to stay home. It's a legitimate reason to have it on a Friday, but it's folks, it's just 2 to 3 days. But anyway, the third dose in general, and we've had over 30 million now of the boost. Those people don't have any more of those flu-like. In fact, the incidence is actually lower. And then there, and basically that was what was mentioned. So I'm going to go through basically the booster. This is Pfizer, Moderna, Janssen. This is what we thought was basically, are they immunocompromised? Yes. Then we administer the additional dose. No. We administer the additional dose. Basically, what Dr. Fauci, the CDC, Dr. Aragon from the CDPH, and Dr. Sequeira for San Diego County are saying is that if anyone comes up wanting a boost, give it to them. We don't want to turn away anyone who wants a vaccine. So in general, that's the philosophy and encouragement for all of us involved in public health. So they've had even any of the 3, they get a boost. Okay. And the question always comes up, and the boost, remember, for Moderna just is half. Okay. Your primary series Moderna is 0.5. The Moderna boost is 0.25. Okay, that's just a fine point to emphasize. Although it's not going to kill people to get the 0.5, but you don't need the 0.5 with the Moderna. So we talked about this. Current clinical trials show that using the same vaccine strengthens the immune response and has an acceptable safety profile. Okay, now what we call heterologous vaccine. In other words, you choose a different vaccine for your booster. Early studies, show that they stimulate a similar or higher immune response than using homologous boosters, which is interesting. So that's why when I get calls from my clinic, the patient had a Pfizer, wants a Moderna boost. I'm not going to say no. Although we need to talk about that, because technically there should be a good reason. The only FDA approved vaccine, full FDA approval, is the Pfizer. So when we give heterologous, it's kind of there's an EUI, emergency use authorization. But for heterologous, technically Pfizer is the only approved vaccine for that. If you receive a J&J for your first, then either boost likely it will produce a stronger immune response than a J&J booster. So it's okay if they, and I almost encourage you to have previous J&J vaccine if they want an mRNA, either Pfizer or Moderna. It's definitely okay. And we know, I just mentioned the Moderna primary seems to offer protection for longer than the Pfizer primary. So, and that's basically what this is with heterologous vaccinations, or booster, but other vaccines different. So currently the Pfizer is the only FDA approved, and that's supposed to be an I, I'm sorry, that was a typo. Basically provides for heterologous additional primary or booster administration following the completion of a primary vaccination of a non-FDA authorized. And I'm sorry, so let's clarify. So the FDA approved, or Pfizer, is the only one that's approved for non-FDA authorized. These foreign produced vaccines like Sinopharm, Sinovac, AstraZeneca, Novavax, the Sputnik as well, that's the Russian version. So if they come in one of those, we need to probably give them a Pfizer booster. It's okay to give Pfizer or Moderna or J&J as heterologous vaccination boosts, except when they come in with these. Okay, might be a question on that. So let's move on. Any questions on boosts? There's a chat.
Dr. Sequeira?
Yeah.
This is Jody.
Hi, Jody.
First of all, thank you. We appreciate you so much. So thank you for doing this for us. I do have a question because I've been trying to figure out what to do. I had the Moderna and got very, very ill with the second shot. So I have had people tell me to get the Pfizer booster, but I've been a little worried about doing that. But from what you're saying, it sounds like it might actually be better to get the Pfizer booster in terms of immune reaction than getting the Moderna. Is that what I'm understanding?
Yeah, yeah, Jody. That the initial studies show that when you get a heterologous vaccine, it actually produces a better immune response. So yeah, I'll try the Pfizer.
Okay, thank you. I just wanted to make sure I understood correctly what you were saying.
Yeah,
so.
and it's okay to take antipyretics like acetaminophen and anti-inflammatories like ibuprofen after you get the shot. That you've heard some wives' tales about it might prevent the immune response because it decreases inflammation, like ibuprofen. But it does really help that after you get the shot, I just go home and prophylactically take Tylenol and ibuprofen. Make sure you take ibuprofen with food, but it really will blunt that achiness and the headache and the fever.
Okay, appreciate that. And I'm just at 6 months, and I heard you say that the Moderna is actually lasting longer. Should I wait the 8 months like they were saying originally?
No. 6 months is for
6 months.
For all boosts. Yeah, I wouldn't wait.
Okay.
I wouldn't
right.
count on the Moderna.
Okay.
And it feel good though that you've had the Moderna. It's probably still decently strong, but we need to. It's going to wane. And we pretty much know that now. And so it's better just to do it and get the Pfizer. It's a lot easier to get the Pfizer now too. That they have the new storage guidelines. Great.
Exactly. Okay. Thank you very much.
You're welcome. Okay, let's talk about therapeutics now. Oh, any other questions on the vaccine boosters, pediatric? No.
No, nothing in the chat.
Okay, great. Okay, so the exciting thing is we've got therapeutics on board and more coming. Okay. Therapeutics are basically treating people who have it already. In other words, medications like antibiotics. Okay, so the first therapeutic update is not necessarily an update because it's kind of older now, is monoclonal antibodies. Okay, just to review, we have 3 of them. Okay, and these are antibodies that basically were derived from previous infection. Okay, and we, they basically, it's like with tetanus, you have the immune globulin and you have the vaccine, right? Well, with COVID, this is the immune globulin. They're antibodies. Okay, so we have this is REGEN-COV, which is casirivimab and indevimab. We've got BAM-EDI, and interestingly, BAM-EDI, the Lilly product, was previously brought in, found to be not effective for the original virus. But interestingly, when they retested it with Delta, it works on Delta. And then everything's Delta now, so it was brought back. So we have BAM-EDI, and we have sotrovimab, which is a newer one, which works on all of the viruses of the coronavirus family. So even if Delta mutates, sotrovimab has been shown to work pretty much on all of those viruses. So basically, REGEN-COV is greater than 76% effective in if given to mild or moderate COVID-19 patients. It's effective against the Delta. And now, importantly, it's been approved for post-exposure prophylaxis. In other words, a family member who lives with, or a skilled nursing facility, their roommate, et cetera. So people are high risk, or you're just concerned about that they've been exposed. It's been shown to be effective, and it's approved. The REGEN-COV, I singled it out because it is approved for subcutaneous administration too. So you don't have to give it IV. The BAM-EDI and the sotrovimab, you have to give IV. IV. The BAM-EDI has also been shown to work for post-exposure prophylaxis as well. These are kind of old hat. They're free. If you need them, basically let us know. We have a line to order them, and once you order them, based on your use, you can get them directly from the feds, from the federal supply, and so they're there. Please use them, and it's for prophylaxis too now, post-exposure, and as you saw, we have a significant population that's not vaccinated, and there's waning immunity. So we need to gird up. We need to basically get all the weapons that we have, because we need to gear in and prepare for this becoming endemic. So that's one therapeutic. This is just coming off, and it will be arriving to you guys soon. Okay, probably in the next month. Molnupiravir. It's a pill. It's an oral drug, and it's made by Merck. It actually works. Really, it's a gene silencing drug. It inhibits RNA polymerase. It actually makes the virus replication incompetent. It prevents its replication. It's shown to have basically to induce a marked reduction in COVID positivity. You got to start within 5 days. There's a 50% reduction in hospitalizations, 100% reduction in deaths, and it actually has been shown to work on influenza and Ebola and other viruses as well. So RNA viruses. So and it is being approved. Probably we're looking to by first week in December. We're working with the state already because I think there's going to be a significant shortage and a high demand for this, kind of like at the beginning of the vaccine. So we're getting ready for distribution to our clinics and to our pharmacies. Now that our pharmacy chain has really developed, the large pharmacies like CVS and Walgreens, et cetera. So we're getting ready to distribute once it gets EUA. Merck has already made quite a quite a few million doses of this, and it's ready to go. There's another one. Pfizer, of course, Pfizer really wants to stay on the edge of this, but they've seemed to have produced another RNA polymerase inhibitor. These are like the same kind of mechanisms for our HIV drugs. And you all notice that basically we don't have a vaccine for HIV, but through therapeutics or through these polymerase inhibitors, we basically have normalized the longevity of HIV patients. So here's another agent by Pfizer. This one produced an 89% reduction in hospitalizations and 100% reduction in deaths. And up here in the blue, that's its name, Paxlovid. And it has to be given with ritonavir. And ritonavir basically is another medication that extends the half-life of this. Okay, and ideally you start this within the first 3 days of infection, and the EUA it has been applied for. So it'll be a week or two after a molnupiravir, but Paxlovid's coming, and so we're getting some weapons to deal with these people who don't want to be vaccinated or who have breakthrough infections. So there's one third. This is a fourth therapeutic, and these are the LAA-beam, the long-acting antibodies, and the chemical names are tixagevimab and silgavimab, and these basically are long. It's made by AstraZeneca. That's the AZ. This is the chemical term. If you want to do a Google now, you'd have to Google AZD 7442. These are long-acting antibodies. It's a single IM injection. The protection is for 6 months to a year. And what we're going to do is probably reserve this for high-risk patients who can't yet be vaccinated or we're worried about breakthrough infections. So people, hate to say it, but who don't want to get vaccinated, we can. This is actually we're giving this, and it's going to be applied for pre-exposure prophylaxis. So, for instance, you've got leukemia and you're on immunosuppression and you're working in a nursing home, high risk. This is the kind of thing where you kind of indication where you get the AZD 7442, the long-acting antibody. It's already in phase 3 trials. The EUA is imminent, but there's no set date, so we don't know. But it's probably in the next 2-3 months we'll have these long-acting antibodies as well. Again, a single IM injection, so it's promising, and the wheels of science in our country, in our world, are continuing to turn on this, and that's why I said we're going to win this war. We may not extinguish the virus, but we're going to win this war. So let's talk about misinformation just briefly, and then I can open it up for some questions. But Dr. Vivek Murthy, who's our Surgeon General, has labeled misinformation as a public health threat, and for every one of these rumors, the rumors that the vaccine has microchips or magnetizes you or causes sterility or causes fetal malformations, all that's misinformation. And unfortunately, this is misinformation that actually picks up listeners. And there are people who really listen to these rumors. So that's why it's important that we address misinformation and that we basically deal with it and deal with it by providing the science. Okay, and that's why I've provided the science to you. So this is an interesting example, Tucker Carlson, he's a conservative news. Actually, I don't know these news, but he has a show, and basically he said that he claimed that 3,362 people died from the vaccine. There's a significant very extensive fact checker article that I can give you a reference to that basically showed, and the CDC actually commissioned this, that there have been basically a review of all the available clinical information, including death certificates, autopsy, medical records, has not established a causal link of any death really to the COVID vaccines. Okay, there may be anaphylaxis, but in terms of a direct effect, mortality, there really is minimal. And remember, we have the vaccine, the VERA system, adverse event recording system. It's received 7,200 reports of death among people who received a COVID vaccine, but a causal link to the vaccine has yet to be established, according to the CDC. So it's important that we deal with these. There are probably a little over half of the people who haven't received the vaccine, about 25-30%, they're just still hesitant. So we need to be A, non-judgmental, B, professional, C, talk about the science and reassure, know where they're coming from. A lot of people are going, they're just hesitant and going out of fear or fear of the unknown. And sometimes it's just inertia. They don't want to get out there. It's too difficult. We tried to eliminate all those things like the cost. It's free. The difficulty, it's not difficult anymore. They can walk down to Rite Aid or Walgreens and get it, or go to one of our CHAISR clinics. So we've got to deal with every excuse and move from there. So, and this is just another example. This was in June, but this came out in September about a 15-year-old who got the vaccine and developed a heart attack and had cardiomyopathy. But the basic, and then died. But there was full extensive research and pathology. The CDC was involved with this. CDPH was involved with this. Showed there was no direct link between this death and the vaccine. So, just another example of the misinformation that can be out there. So, hopefully, I've been, being able to give you a background of where we are, the science behind the vaccine, the virus, the mutants, the rationale for the booster vaccine in terms of natural immunity, and talk about the pediatric vaccine and the therapeutics. And I'll leave it open. If there are no questions, I'll give you an extra 10 minutes if there are available for any and all questions. And I'm completely fine if there aren't that many of you. Just break mute and ask your questions.
That was a lot of information, so I know that there's bound to be some questions. Does anybody have any input they want to give on, are you seeing a lot of vaccine hesitations or hesitancy still? How are you guys doing giving the boosters? Are you seeing any want in your communities for the booster? Any sort of feedback? Gita?
Yes, good morning. Thank you so much for the information. I just had a quick question. We are just starting to give the vaccine. In fact, today is our first series of patients that are coming in for the vaccination.
Great.
And I did some research, and I was wondering, I just wanted the confirmation about the forms that they are filling out. These are not established patients of the facility, so they're just coming in for the vaccination, and they won't be coming back as regular patients. The CDC forms and the HIPAA form, would that be sufficient in your opinion, as far as, the forms that they are filling out, or do they require to do the full medical history form?
Yeah, I think, Gita, that's more of a local issue, and I would, as a former administrator of a hospital emergency department, I would say that you need to generate some record.
Mm-hmm.
It covers your malpractice,
Right.
and there's a record in case someone claims something that wasn't done. So and work with your with your clinic people and your administrators, and you can create an abbreviated form.
Mm-hmm.
But some way to just track what was given, what was done,
Right.
any side effects, any anaphylaxis. Just again, so you have a record for it.
Right. Thank you so much.
Welcome.
Thank you. And then in the chat, we did hear from Carol Wood at DAP Health, located out in Palm Springs. She said that they have waning interest in the initial or the booster vaccines, but they continue to offer to all unvaccinated patients, volunteers, clients of the agency. And all of their staff is vaccinated via the mandate, and the booster is voluntary. So but she doesn't have any statistics on who's received the booster so far as of her staff. But that's good to hear, Carol. Things are going all right out there.
Yeah, thank you, Carol. But Carol, if you could present this information on waning immunity, and really I'd encourage you. I'm fine. We don't need to mandate the boost, but I really think, to really continue to hammer at this virus and to protect more people, especially your staff. You don't want your staff to have a breakthrough infection. So I'd encourage it. But actually, yeah, I'm just appreciative that you've done a great job with getting all of your staff vaccinated. That's huge. So,
And Dr. Sequeira, this is Jody again. Do you think, again, that in another 6 months, we're going to need to be boosting everybody again? Like, for instance, if I get it in December, will I need to boost again next June?
Well, it depends, Jody. We get another Delta, darn Delta variant. It's really changed things, and then that's the reason. Like even I saw something on Fauci. He talked about it. They're saying, when are we going to get rid of this thing? Well, the problem is now we have waning immunity. We've got the Delta variant, and there's so many different variables. And so what we're going to need to do, and it's a new disease and it's a new pattern. It will have to look out at 6 months, and if we have another little, like you saw, another little bump like that, and maybe we're actually. Our surveillance is much more tight. We're doing systematic 10% whole genome sequencing of our positives. So we're really looking. There's a whole new group of whole genome sequence geneticists on this. So we're looking for variants. That's why we know there's greater than 150 subtypes of the Delta variant. So if something new and significant comes up, going to be watching it like a hawk, of course.
Okay. We're just always curious for, trying to stay on top of making sure that our members have, access and supplies and everything that they need. So I appreciate you letting us know. We'll just wait to watch what's going on with you and CPCA, and try to keep everybody abreast of what's happening.
Great. And Carol, I just noticed that you're with DAP Health, right?
Yes, I just thought to follow up on Jody's question.
Carol, your audio is really low.
There you go.
Following up on Jody's comment, I don't think right now we can say that this is seasonal. It seems to be just throughout the year. But the question keeps coming up, do we think that, or is it too soon to determine whether this becomes an annual vaccine, such as the flu vaccine? And the question would be whether or not it's seasonal, because when is annual? So anyway, that's, I think, kind of the direction that that Jody was going, and the question that we continue to ask amongst our infectious disease specialists.
Absolutely. Great points. We do know that the coronaviruses are in general seasonal. So there are changes in our human behavior with the season that promote viral propagation. It's cold, so people go inside. So congregate living, the percentage of congregate living increases. And so all that tends to stimulate an increase in rate. And we saw last December, of course, December, January, how big that rate was. So I'm thinking I would predict maybe not every 6 months, but at least every year. And the other thing is, back to one last thing on Carol, your clinic. If your clientele is a large proportion of your clientele is HIV patients, I would definitely make sure that the staff think about taking that booster, because you can get breakthrough infections and colonization.
Well, we recommend it. We're not requiring it at this
Right.
time. I'm going to guess, just anecdotally, that perhaps 70% of our staff receive the booster. Many in the community, because it's so available, and we vaccinated some as well. So we did offer it and had we probably gave 100 boosters to staff or volunteers. Many had already received it. So we're just guessing, and we're not requiring that they report the booster like we did the initial vaccine. So it's difficult to really definitively capture that data. But I think, I think we could comfortably say 70 to 80% of our staff received a booster.
That's really excellent. Desert Age Project is amazing. You guys do great work. So.
Yes, they are, and so are you and all of our members that are on the line. We may be a small group, but I think we have 6, 7, maybe 8 different organizations. So this is really valuable information for us all to take back to use for education, and we'll be sending it out to our community partners, and I'll be sending it out to the board today. And do you care if we put you on our YouTube channel?
I won't look at it, but I hate to see myself on film. But
we actually
yeah,
get quite a few people that then tune in and listen. So if you're okay with that, but we just really appreciate you, Dr. Sequeira.
Well, thank you. And I appreciate all of the clinics and the entire CHAISR organization, of course, as I started out with. And I really, in this job, we couldn't do it without you. And we're only as good as every one of us. So hope you all have a great Thanksgiving. Recharge, and get ready for the long haul. But we're going to win this war. So.
Thank you, Dr. Sequeira, and thank all of you for joining us today. Like Jody just said, we will be sending out the recording, and then also the YouTube link if you would like to share that with your other staff members. Carol, did you have anything else?
No, I just wanted to say thank you, and I need to jump off for another call. Thank you.
Okay. Thank you. And we will see you guys next month. In January. Thank you.
Okay.